Yep, okay. All right, so we're gonna go ahead and get started with our session today. Thank you everybody for joining us today. This is our second session of our community of practice on the role of health centers to provide primary care for justice-involved individuals. In today's session, we will be focusing on primary care in the post-incarceration period. This is just a few reminders about that all participants are muted upon entry. Please make sure that you engage in the chat if you have any questions or anything that you would like to share with us today. Please also raise your hand if you would like your line to be unmuted, or since we're just in Zoom meetings, you can just automatically unmute your line. This meeting is also being recorded and the slides will be sent to you all via email after today's session. The mission of NCHPH is to strengthen the capacity of federally funded public housing primary care grantees and other health center grantees by providing training and technical assistance. The content of this webinar is 100% financed by HRSA and do not necessarily represent the official views of the U.S. government. And with us today, we will be having Dr. Kevin Lombardi, that you guys may have met during our first session. He is our Director of Research, Policy, and Health Promotion, and he will be presenting and leading today's session. And moderators, my name is Filipina Sandoval. I am the Technical Assistance Manager here at NCHPH, and with us, we also have our colleague, Olajumoke Oladipo. She is the Health Communications and Research Analyst, and we'll both be taking care of the logistics for today's session. And now, without further ado, I will pass it on to Dr. Kevin Lombardi to get us started.
Hi, everyone. Welcome back. Today, we're going to take a step forward and go from epidemiology into action. Next slide, please. We are going to cover, yes. Well, no, you can go to the next one, learning objectives. Sorry. I'm going to go over them in a sec. Yeah, so last time we went over the epidemiology of the post-release period for justice-involved individuals. Today we're going to plug that into reality a bit and go through a longitudinal case study that covers a patient through the 30-day release period and looks at areas where there are particular dangers for loss to continuity of care in particular. Next slide, please. We will touch all of these as we go through that. From epidemiology to action, we're going to focus on these three main areas because they are, I think, easy to understand and they're low-hanging fruit as far as making systems more effective. One, medication disruption, and remembering from our session last time that folks typically do not receive medication when they are released. They receive it in prison or when they are in jails, but they do not receive it when they've been released. And the post-release period is an important time to, one, figure out what those medications were, titrate them to their new reality. Their bodies are in a very different context from in the post-release period. Sometimes it is more stressful, sometimes it is less stressful. There's different food, there are different social interactions. All these things affect medication, in particular the chronic medications, the diabetes and the hypertension drugs. So these likely need to be titrated over the course of 6 months to a year. Loss to follow-up is the real danger that we want to avoid as often as we can. In particular with patients who may have psychiatric issues, history of substance abuse. The post-release period is very sensitive and it has very high risk of overdose and relapse. So we want to make sure that folks are getting into the health center and they're getting the care that they need. And three is the navigation gaps. I mean, imagine being in a federal institution for 5 years and then coming back into the world. Think about your own life, how much things have changed in 5 years. Now imagine dealing with that mentally all at once. It's immense. And the important point there is that systems change too. So if someone understood how to get health insurance in the past, they may not understand how to do it now. If they felt like they were capable with technology in the past, they may not feel like that now. That is just the reality of change over those years. And 5 years is just an example. You will find people in your practice who have been who are post-release from 15, 20 years. And you can imagine the immense adaptation that needs to be done coming from a period outside of the general society for that long. It is terrifying when you think about it on a personal level, how overwhelming it is to enter back into a world where social relationships have changed, people have aged, people have died, they have moved, and you are in a location where you may not have social support, and you're expected to um, adapt all at once. These are the three things that tend to be the most sensitive and the most high impact at the same time. So we're going to plug them into the case study and focus on them for this session. Next slide, please. And I would like to introduce Mr. Stevenson. We'll be following him over the next several sessions in his difficulties in adapting to the post-release life. Mr. Stevenson is a 41-year-old male. He has a history of hypertension, type 2 diabetes, and a long-standing history of opioid use. He was seen at a rural health center 5 days post-release from a 3-year state correctional institution sentence. The patient was referred to your service by a county-based CHW who met with the patient the day after his release. He has no insurance, but he notes that he submitted an application with the help of the CHW this week. So let's kind of take an overview of this individual. We have a handful of serious chronic disease issues. We don't know how advanced they are, but they are present. A history of opioid use, and also some advantages here. This patient was came from a county that had a system to refer him to care. So we have him because that CHW, the county-based CHW, signed him up for health insurance. That being said, his health insurance application has been sent in. There's no note here of approval. So that depending on your health center or what institution, that may be a barrier or it may not. It depends on the policies regarding that. And this is one of those gray area places, but typically organizations will accept the patient but bill once the insurance has been approved. It is a high risk. It is a risk for the health center financially, given that you never know if the insurance is going to be approved until it is approved. But most health centers choose to give that care because of the high risk individuals, two high risk individuals like this. And that is my recommendation as well. It lowers the value, the cost of care overall to your patient population. It is a good thing, and this is a good thing. Next slide, please. So what happens in the first 15 minutes? What should occur in the next first 15 minutes? And I'll ask you to go back uh, to the last slide, and we'll take a moment and think about it. So this guy walks in, 41 years old. He's got a history of these chronic conditions, 3 years at a state correctional institute. What are your priorities? Put your thoughts into the chat or just unmute and speak if you feel like you have something. I'll give you a second, and then if there's no one, I will take it myself. So I'm going to pick on someone to be Socratic quick, and Fide, you'll be the first one. Does this seem like a high risk individual low risk individual, moderate risk? Where does he fall on the risk spectrum for you?
I think he's a high risk individual given
Hmm.
his history, um, and also his age. Um, he has a history of hypertension, diabetes, and opioid use.
Wait, did you say
Um,
age?
yeah, age, I
He's
think.
41, B-Day. Be nice.
I'm sorry. Well,
He's only a
I
couple
mean,
years older than me. Oh, Lord.
I I know, but like, well, I'm not thinking about that, but sorry. But I'm just thinking, like, he's if you look at it from that perspective, I think he just has a lot of things going on already,
Mhm.
that he needs to try to c control or keep on or manage better. I don't know.
Mhm.
I think like as a CHW, I would try to do like an assessment of like where he's at currently. Um, Maybe like a lot of like the status of where he's living. Is he employed or is he like looking for a job or I don't know, like, on all those kinds of things. Um,
Yes, a non-medical needs questionnaire
yeah.
would take care of that, and that's what one of the high priority items for this part of the visit. Um, and I'll say that uh, continuity of care doesn't just get solved with one visit. If someone shows up, you need to make sure that they show up the next time. Um, and managing that for an individual like this often
Mhm.
requires social support. Folks typically don't have a vehicle waiting for them when they come after a 3 year sentence at a correctional institute. And so it's unlikely that this individual has transportation, for example. These are things that you can just predict. The social needs questionnaire gets those on paper and tells you what you need to do to support the patient. Um, so 100%. Uh, is there a diagnosis or something in the past medical history that it really stands out to you as high risk?
A history of opioid use.
Hmm.
Yeah.
Yeah. So we're going to want to know a lot about that, right?
Mhm.
Did he use when he was in prison? Was he sober when he was in prison? Does he have a history of overdoses? So this is a very, very high risk window for this individual, given that history of opioid use. Stress is a major driver of relapse, and folks will feel the need to relapse when they are going through times of intense adaptation. So this is a high risk window. And although you can never control everything, you can control a lot. There is let's say, the internal locus and the external locus. Things you control, the things you do not control. We don't control the individual's peers. We don't control the decisions that they make, but we do control the resources that they get. And That makes the environment more stable, less stressful, and the adaptation smoother. That lowers risks, and from a cognitive science perspective, it makes someone less likely to relapse. Every person, it makes them less likely to relapse. So these are important things. Next slide, please. And again, past. Oh, here. Yeah, good. You did it right. Okay. So some key information for the first 15 minutes. Let me pull it up on my end here. Um, so loss to follow up is another main concern we need to make sure that we cover for. Um, and Sort of the key information that you should be able to get within the first 15 minutes is the following. One, the incarceration status the past 30 days. This should be on intake paperwork, either on a social needs questionnaire or not. It is, and I will say, it is often not put there on the templates, and you need to add it yourself. Um, but From the perspective of patient continuity, the sooner you know about someone's incarceration status, the more you can do during the visit, and the more likely they are to show up at their last appointment. their next appointment. And I'll give you the example of someone where the incarceration status isn't asked and it's maybe incidentally comes out during the clinician interaction. You lost all that time where someone could be coordinated to care. He could be connected to the referral to social services could be sent out. The clinician could have known before that person walked into before they walked into the exam room that that person had that incarceration status, and they could have prepared a treatment plan, or at least looked at the history in a way that prepared them for that interaction. So we miss a lot when we don't ask this early on. So as early as possible, intake paperwork and social needs questionnaires are the best high priority places to put that from a sort of intake real estate perspective. Those are the high value areas to put that. Two, the medication information and status. What medication does this patient have, and does he have, and has he been taking it? Uh, so again, things that are done at intake and in the social needs questionnaire. The presence of insurance or application, uh, and a comprehensive list of the of any high risk conditions. This is typically done with intake paperwork, but that information needs to be shared with providers before the patient gets into the room. Um, yes, absolutely. So, I will say, and I will say for the language for a question, have you been released from jail or prison in the last 30 days? Is just a simple way to put it. Have it automatically flag a referral and CHW intake, and that one step will make things a lot safer for these patients and a lot smoother for the providers. Um, People in the post-incarceration period are not your typical patient, is something that I think is very clear to everyone from this point. But to sort of differentiate, Mr. Williams, just a patient coming in for his annual wellness, or Mr. Stevenson, a patient coming in post-incarceration 3 years, the amount of effort that needs to go into that appointment is night and day. Uh, the first individual isn't going to require the sort of intense referrals, CHW intake, careful attention to detail that Mr. Steven is going to be. It is simply a different type of patient that requires a lot more hands on deck in the clinic. So the earlier you ask, the more you can digest during the visit. The more you can digest and accomplish during the visit, the more likely the patient is to be safe at home, the less likely they are to overdose, the more likely they are to show up again, and that helps both your patient and the overall cost of care at your health center as well. Uh, Next slide, please. So moving on with Mr. Stevenson, pull it up on my end here too. So we have some additional information. He goes through the intake process, and we receive the following. So has a blood pressure 168 over 102, heart rate of 82 beats per minute, respiratory rate of 12 beats per minute, previously prescribed lisinopril for his blood pressure. It's a typical dose. Metformin, 1,000 milligrams BID, medium to high dose. No medications in 5 days. That's the period since his release. Complaints, fatigue, headache, poor sleep with night awakenings, and depressed mood. Okay. What do we think? What pops up as red flags in this information? Things that need to be addressed for this patient, either clinically or non-clinically.
Yeah, definitely.
Yeah, you nailed it. And I have a question for you, Maria. Besides the fact that this patient has a diagnosis of hypertension,
Hmm.
what's driving that blood pressure high for him?
Well, I guess, can you hear me okay?
I can.
Okay. I guess maybe because he hasn't had his medication in a couple days. So
Hmm.
probably post discharge from he was probably being seen and followed pretty closely while at the, while incarcerated. And then once not, medication and all of that stops, in terms of just, being able to be provided for him is what I would think.
Yeah.
And then, so yeah, so I would say that blood pressure would be something that he needs to really look at, or whoever needs to really look at to help him, overall, um, and then address, and that might help with the headache and the fatigue, poor sleep, etc. And then maybe look at his mood and how that can be supported.
100%. And you've gotten into something there is that these things are not isolated, right? You don't have hypertension over here and depression over here. If your blood pressure goes from, say, 130 over 80 to 168 over 102 in 5 days, you're going to feel that in a lot of different ways. And stress and anxiety is one of them. So you do this patient a big favor by just giving him his lisinopril 20 milligrams daily and making sure he gets it there. But my other question for you, Maria, is do you think that stress could play a role here? And if it does, is it driving that blood pressure or driving anything else?
Oh, I think stress is a huge component to what's going on with him. I mean, he's just getting out. He doesn't, who knows if he knows where he's going to live, where he's going to sleep, where, he may not have the support system he needs. He's probably just flying by the seat of his pants at this point until he can get his bearings and get the support that he needs.
Hmm.
Um, that's kind of what I would think. And stress definitely would cause, you know, um, all the other symptoms that he's having. Um,
100%. On a chemical level, cortisol and epinephrine goes through the roof. Um, And I mentioned this a little bit earlier, but if you've ever worked with individuals like like Mr. Stevenson, they'll tell you that that post-release period, you can't relax. They will say that they missed parts of incarceration. They miss their friends, they miss their routine. Everything that they lived in has been completely wiped. And of course, for them, this is a good thing. They are re-entering the community, but it's not an easy thing.
yeah.
So
If I could share real quick, on a
please.
personal level, it was really hard for my family, but I had a younger brother who was incarcerated, and he exhibited a lot of these symptoms when he first was released. And he actually preferred to be back in prison than out in the community because it was so stressful and so hard for him to be able to adjust. And that was really hard on my parents and my family and I and my other siblings to see that he was kind of falling back into that, even though we did everything we could socially and, emotionally and everything to help support him. He Yeah, he missed his friends, he missed the community that he had developed, um, in there, and he ended up committing another crime just so he could go back, and that was extremely difficult for our family to accept. But we still love him anyways, but still, you're right, it's hard for them to make that transition. It's very stressful.
Yeah. Well, that's the thing about family, right? So I think you guys took the right perspective there. Support whether things are going the way you want it to go or not. And I think your story makes a kind of conceptual, like solidifies the point that this is complicated. Um, uh, the wanting to get back into prison is a common thing that you'll hear from individuals who have gone through this, and it's not just one or two. It's a big piece of the pie. And when you sort of break it down and you understand how scary that transition period is, it makes a lot of sense. It makes a lot of sense. And what I'll say is every individual is different. And our goal for them is for them to be healthy in the community, period. And the more support you provide, the more likely they are to get to that point. If they don't get to that point, it's not a failing of you, it's not a failing of the system, it's just a complexity of the individual issue. But it comes back to the internal locus and the external locus. Internal locus is what you can control, external locus is what you can't control. And the external locus, I don't like to think about that too much. You know why? It's wasted time. There's nothing I can do about it. I like to think about that internal locus. And for these individuals, a lot of them are going to be just like your brother and are going to go through that same cycle. And I don't think about that part of the story as much as I think about let's get this patient on his blood pressure and make sure he can come to the clinic appointment because that's something I can control and that makes it more likely that he stays here and he stays healthy. And I say that because not to ignore those things, they are important from a sort of interpersonal connection or understanding someone's story. But they are not a focus of effort typically because there's nothing that can be done. The systemic aspects of caring for justice involved folks will drive you crazy if you think about them too much. How the system is run, how it treats individuals, it will make you angry. Instead, focus on the things you can do for that one individual person to make their lives better, and you will feel a lot better. You didn't make the justice system, you're just fixing things as they come to you. So focus on those very small things you can do, making sure someone gets to an appointment or has all the support, has an extra reminder, all the paperwork is done critically. Let me tell you, you save people's lives every day doing paperwork. Just making sure data is exchanged. These are the things that you should focus on. And what I'll say is one of the kindest things you can do for someone is making sure they get the support that they need or making sure they get the service that they need. And I'll say that that's good for the patient and it's good for your health center too. So that's where the focus goes from my perspective with this. And I will just say, just broadly in medicine, if you want to get, if you wake up every day and you want to get frustrated or you want to get angry about things, you'll find plenty of things. It's an endless list. It's your choice if you focus on the things that you can change and you can on both an individual and a systemic level. And when you do that with patients, you see the change over time. So 100%. And some things here. The chronic disease and the depression are intertwined here. Poorly controlled diabetes and poorly controlled hypertension makes people feel depressed, even if they are not clinically depressed. So getting that medication going is a great way to help with this mood as well. Mood is connected to overdose. So if someone is depressed, they are more likely to overdose than if they are not depressed, just off the cuff. So just dealing with that one thing, you lower that person's chance of overdose. All of your actions have consequences for patient care, and they're often um, more interconnected than we think. Next slide, please. Okay. The patient is seen by a health center primary care physician who obtains the following details about the patient's opioid use history. Here's the important stuff. Um, when someone shares that they have a history of opioid use, you always want to know what they use, how often they use it, how long have they used it, do they have a history of overdose, and did any of those overdoses result in hospitalization? These are the things that you really need to know because they affect care and they affect how you treat the patient. So one, weekly fentanyl use prior to incarceration. Okay, well that's already, well, I'll give my comments at the end. One overdosed in 2021, two overdoses in 2023, with one requiring hospitalization in the ICU. Um, uh, did not use opioids during incarceration. Experienced intermittent cravings prior to release, 2 to 3 times per week. Okay. So just to sum this one up, because there's a lot of important information here going on with this patient. OUD history, weekly fentanyl use prior to incarceration. With the opioids, the opioids with short half-lives spike blood concentration very quickly and are more volatile and more addictive. And when we go from the spectrum, we have sort of like things that pills that are time release on one side, and on the other side, we have things like fentanyl. So fentanyl is the among the most addictive forms of opioids, and it is among the most difficult to stop using. It causes people intense pain when they stop using it. I've seen patients spend 20 years trying to get off of it when it was medically prescribed. So when we look at this individual, he's not using, and that's a huge, huge deal. And we want to support that as much as possible. That is likely a core part of his identity. That is a huge accomplishment. And what I'll say is, I went to medical school. He got off fentanyl. I'd say his is more impressive than mine any day. So I want you to keep in mind when you meet people who have gone through this and gone through opioid use, it's an immense accomplishment, and we want to support them as much as we can and tell them that, and tell them that they're doing great. So, we had three overdoses, one requiring hospitalization. He was then incarcerated, so the opioid use is likely related or in some way to that incarceration or the behavior that led to it. No opioid use during incarceration. Good. Folks can typically find it if they want to. So that I think speaks to the transition this individual went through. Um, and he experienced intermittent cravings prior to release. So 3 times a week throughout his sentence, he was feeling like he wanted to use. That's a hard time. That's a hard time. Next slide, please. Mr. Stevenson then provides the following additional information about his addiction. Cravings since release, daily. Notes, I have not used yet, but I feel like I am getting close. Treatment history, not started on buprenorphine or methadone during incarceration. No medication for opioid use disorder upon release. No follow-up OUD care arranged. So that should get your blood pressure high because it's almost asking for someone to overdose. Also, that's typical. Individuals do not typically get uh, prescriptions when they leave, including for opioid use disorder, and often do not receive treatment in prisons either. So, prisons or jails. So, keep in mind that when someone has been through that, they didn't get treatment, they didn't get education, they didn't get medication. You're starting from the beginning. They may not even have had overdose training. There's a lot to be done and a lot to teach. These are things that should typically be offloaded to or delegated to a colleague that does it for a living. And I will say social workers often fulfill this role, CHWs often fulfill this role, case managers often fulfill this role. Different people do it in different institutions. It is critical no matter who has it in their hands. Doctors will do it in some situations too. It needs to get done though. And the important thing is the person who does it needs to put it in a note and needs to put it in the EHR so we know. So very important there. Next slide, please. Okay. And I'm going to read this, and then Fide, I'm going to ask you to go to the last slide so we can think for a moment. But take a moment, and what are the top 3 priorities for Mr. Stevenson's care so far? 1, 2, 3. You don't need to explain them; just put them there. Anyone have any priorities for me? 'Cause I have some. My list is long though, but planning on time, I'm going to go ahead. So here are my target priorities for this patient. One, we need to initiate treatment for opioid use disorder today. The system has failed him. He has not received treatment. There's nothing we can do for that with that. However, he's in a new system now, this health center. So we're going to make sure he gets the treatment today. Typically, what you'll do in office is provide buprenorphine and sort of titrate it to relief. And if your office is set up for that, we can do that. Ours office is set up for that, and we can do that. The other thing is, I'm very worried about this patient's risk of overdose. So he's going to need an naloxone kit, and he is going to need training on opioid use disorder today as well. Critical safety move saves lives. Restart his medications, lisinopril and metformin. You want to stabilize behavioral health as well. I want to see a screen that for depression, anxiety, and if necessary, the patient can be prescribed medication today to work on that. So a lot to get done. And I will say this, I mentioned all these things and we're kind of going through a wish list here, but let's just be practical for a second. This guy comes in on a busy day. We've got 15 minutes. It's very difficult to get all of this stuff done sometimes. That's just the bottom line. So you need, every patient is a triage issue. You're never going to deal with everyone's issues. You're never going to be able to get through them. Everything is triage. Pick the most important things and focus on them first, get them done first, and start with the opioid use disorder with this patient. That's what I'll say. Get as far as you can. And the CHW and the follow-up can deal with a lot of other things, but today's focus is immediate needs, and that OUD and those chronic medications and that depression, those are the priority for me. Next slide, please. And of course, just to go over our priorities again, initiate treatment for opioid use disorder today, restart his lisinopril and metformin, and follow up in 3 months, and stabilize behavioral health, assess depression, and provide intake support. So with restarting medication, so I think he was on lisinopril 20, metformin 1,000. So when you are in a prison or when you are in the community, you are a fish in a different fishbowl. And those different fish bowls are going to affect your body in different ways. And there are two important chemicals there, hormones, cortisol and epinephrine. That's your short-term stress response, epinephrine, and your long-term or longer medium-term stress response, your cortisol. Those drive glucose sensitivity and those drive blood pressure. Very, very important. So for individuals who were very well controlled on 20 milligrams when they were when they were in incarceration, and that was just their normal life, and then they transition to the community and they are stressed out, don't know where they're going to live, can't get anywhere, don't know where to eat, what to eat, having arguments with old friends, socially isolated. How do you think their blood pressure is going to look on the same dose? Well, it's going to be higher because they're going through more stressors. So these doses often need to be titrated. But here's the complexity. This patient hasn't had their medication in 5 days. So what do? Start with that baseline dose, see them very soon. And I said 3 months here, but I later changed my mind to 7 days. So ignore the 3 months. It's 7 days. I want to see this patient in a week and check their blood pressure again. And I want them to check it at home as well. So that'll give you a good assessment of sort of where they are and where you need to go. And behavioral health. assess that depression now, because as soon as he goes out the door, if you don't assess it, it has the potential to drive an overdose. It has a potential to drive social isolation. It has the potential to drive other negative outcomes that are going to have a huge impact on this patient's life and might send him in directions that we don't want him to go. High risk of mortality, high risk of reincarceration, risk of additional social isolation. We don't want that. Next slide, please. Let's go through the workflow. Reentry care workflow. So one, we need to do identification at intake. Make sure that either the intake paperwork or the social needs questionnaire is asking an individual if they have a recent history of incarceration. And I'll add, even though I did earlier, that often these screens do not have that. It's not there. You need to add it yourself. Very high yield. It'll make the appointments easier, and it'll make the appointments easier because you're treating the patient earlier with that in mind, and it makes the patient safer too, because you're able to do more during the visit and able to coordinate things more appropriately. So just off the cuff. Two, risk stratification. When we looked at this patient's record, we saw opioid use disorder history, depression, multiple chronic diseases. That raised him up in the risks stratification, and we were able to put more resources into it, more attention into it. You can't go 100 miles an hour on a back road. And for patients, you need to know what their risk stratification is, because every patient is triage. In time, every single patient you will ever see, you'll never have all the time you need to take care of everyone's problems. There will always be another one. But you need to take those high risk things and focus on those and delegate to your colleagues in community health and social needs or social work and yourself for that next visit. To the clinical stabilization, we need to make sure that things that need to be stabilized are stabilized, and that blood pressure and the cravings, increasing cravings, need to be dealt with today. So it's in office. Behavioral health integration, assessment and treatment as needed. And then here's a big one, the CHW integration. And I will say the CHW role here is not necessarily just the CHW. It is navigation and social support, which is done by many different positions at different parts of the country, different organizations, and so forth. If you are the one that is doing navigation and support, you are number 5. So that is a critical link to making sure that this patient is safe, is that number 5. What I recommend is the coaching style relationship with the patient, where you follow up either in person or via the phone within a couple of days of their appointment and start working through resources and so forth. Then stabilize and arrange follow-up. I will say that sometimes folks don't have a phone yet at this point. So you have the phone of a relative, you have an address that may not be accurate. So arranging follow-up is probably the hardest part of this. But it is worth the investment from a patient safety perspective. Next slide, please. Okay, well, I think we did this question already. Next slide. Okay, let's go over the patient risk. Again, every patient is triage. After a while, everything is triage, if you want to think of it that way. So he's in the highest post-release window. He's 5 days post-incarceration. He has a history of past overdoses, 2022, 2023. He has increasing craving frequency, huge red flag. No medication for opioid use disorder, from what we know, ever. And that also likely means no training in overdose education either. No follow-up care arranged for behavioral health or OUD treatment. Huge deal. Huge deal. Next slide, please. Okay. It's time to prioritize. Mr. Stevenson, let me pull it up on my end here. Mr. Stevenson and his PCP discuss initiating treatment for OUD today. His initial dose is started at 4 milligram, and this is buprenorphine, by the way. Started at 4 milligram and titrated to 8 milligram for effect. 60 minutes later, on assessment, Mr. Stevenson reported a reduction in cravings, reduced blood pressure, 152/82, and reduced anxiety. No signs of precipitated withdrawal were observed. Good. Patient was also provided with a naloxone kit and education regarding overdose risk. Yes, 100%. Let's focus on the things here. Okay, so one, it starts with the conversation, right? The patient needs to consent and agree. We did that here. He started at an initial dose of 4 milligram and moved up to 8 milligram. That speaks to sort of the severity of the withdrawal effects he's experiencing. An hour later, he's noted to not only report the reduction of cravings, but his blood pressure has gone down too. Why is his blood pressure gone down? Does buprenorphine treat blood pressure? What do you think, Fide?
Um, can you repeat the question again? Why?
Why did his blood pressure go down? We're treating him for OUD. That seems,
I
is that
think maybe
connected?
maybe he's not so stressed
Yeah,
anymore.
reduce stress. Yes. Oh wait, Jamoke, did you just steal it from Fide? Rude.
I think we said it at the same time.
Th- Thank you, Jumake.
Yeah. So one, like buprenorphine does have an effect on blood pressure. It does affect it
Mhm.
chemically to a small degree. But the bigger impact is the reduced stress that the individual experiences. Yeah. He could have been having a craving right there. I mean, think about it. The guy was having 3 times a week cravings before. He's released out in the world, right? Let's say it's winter too. Let's say it's in the middle of winter and it's I don't know, in Chicago, it's cold, right? We get some Great Lakes air in there, and he goes from one world to whoop. And let's say he was in prison in Florida and he went back to Chicago where family was from. So he goes, and that's a transition that happens. So this individual is having increasing cravings every day. Everything's piling up. Everything's complicated. How do phones work now? Like was there Uber 3 years ago? I don't, things changed a lot. So that stress is driving increasing cravings. And he could have been having, he walks into the office, hasn't been in a doctor's office in the community for years. That's going to drive stress too. He's going to be feeling those cravings just right in front of you. So yeah, treating him there takes care of multiple problems at the same time. Reduced anxiety, lower blood pressure, and reduction in cravings. And of course, no signs of precipitated withdrawal. Um, why is it important to give him a naloxone kit and education? If he overdoses, don't they just call 911 and they deal with it?
Hmm.
Right?
Mhm.
No, 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 no. Think about it though.
No.
Think about it. What does the group think? If someone overdoses, they just call 911, right? Why do we need to provide them with a naloxone kit and education? Why would we need to do that?
Maybe in case you see somebody else do it. I don't know. No, maybe not. I don't
Yes,
know.
it's that's one example, yes. If he's around the stuff, well, I'll tell you this. Um, is he at a high risk of overdose, Maria?
Yeah, I would say so.
If he has a naloxone kit around him, if he overdoses, is that a better situation than if someone finds him and calls 911 and we have to wait?
Yes.
100%. And that's the key life changing difference there. Yes, yes. Mary, you stole it from me. You did a Jamoke and
Okay.
you stole it from me. Why is immediate care important for someone overdosing? I'll give you a second and then I'll take it if you're unable to speak. What does when you overdose, what does it do to your respiratory system? How does it affect your breathing? If anyone's ever seen someone overdosing before, how does it affect your breathing? You can take guesses. Fide, what do you think it does to your breathing?
I think it cuts down your oxygen levels, right?
Yes. And okay, Mary just Jamoked you again. Mary, you sniper. Yes. And yes, 100%. And it depresses
Mm-hmm.
your respirations themselves. Yes,
Mm-hmm.
like people, their ox level of oxygen will go down, but it's because they are not breathing. It
Mm-hmm.
depresses the actual respiration effort. So if someone overdoses, and why do people overdose, right? It's not just like you don't just throw a dice and this is the day. Uh, when you're buying, say, street heroin or you're buying something that's from a drug dealer, is that a standardized dose? No.
No,
You don't
it's
know
it
what's in that
varies.
stuff. You don't know if MDMA is in that. Like, you don't know if fentanyl's in that. You don't know if there's a synthetic opioid in that. Street drugs are dangerous because they are unpredictable. You don't know what's in it. Prior to medical school, I was a paramedic in Lynn, Massachusetts, which was, let's say, an epicenter of the opioid epidemic. And in 2013, I gave naloxone to 7 pregnant women, 7 of them. It was the same summer. This stuff is addictive. When you see pregnant women consistently overdosing, that's someone who couldn't get off of it, who got pregnant. And I've had conversations with people about that, and they have said exactly that. So it just shows you how addictive this stuff is. And also, it's unpredictable. So we would have this situation where they would tell us, be careful because there was a bad shipment, they would call it. And essentially that it was the street heroin was temporarily like had a lot of fentanyl in it just because of the delivery that had come to the area. So we have weeks where we'd just be busy all night doing overdoses, naloxone here or there. That's how unpredictable it is. And this patient, if they go home, God forbid they do use, what if they use on that one day where there was some fentanyl in the heroin and they didn't know? Well, whatever dose they are used to taking, they're going to get 3 or 4 times as much concentration. That means that's where the overdoses really happen. So when you overdose, your breathing is suppressed chemically by the opioids. You cannot breathe. You've got 10 minutes from when you stop breathing until you start getting brain damage. So that 10 minutes is the golden window here. And if someone has a naloxone kit on their person or they have it in their house, that's when a relative can intervene. People aren't, doing it on themselves when they're overdosing. They're not able to do that. But it's often family members that are able to provide this very quickly. And I'll say put the stuff all over the house if someone is at risk. Put it everywhere. Put it in communities because it really does save lives because you only have that 10 minutes. So for this patient, we want to make sure they have the naloxone kit, and they need to have that health education too. Uh, he's overdosed 3 times. So this is something that has happened before, and if the right and given 3 overdoses and in the post-release period, this is a very, very dangerous week for this patient. Very, very dangerous week. It is amazing that they haven't used already. It's amazing. So that, and also sort of just to bring it back, um, uh, when you meet someone who has a history of addiction, who has gone as far as Mr. Stevenson, throw them encouragement whenever you can. Because they often don't get it and they deserve it. Because let me tell you, I don't think there's anything harder out there than getting off of opioids. I've seen it in patients, I've seen it in family members. Let me tell you, there are few things that are more difficult. And when you put that together with being someone who is justice involved in the post-incarceration period, that is a killer cocktail. That is a killer cocktail. So give these folks all the encouragement you can. Small acts of kindness make a difference. So that's where I'll stop at that. Next slide, please. Okay, as far as additional resources and sort of the consequences, I'm going to breeze through this. So referral to OUD treatment and confirmation of that referral. I want him to leave with a 7-day supply of medications. Let's make it 14 days because he's coming back in 7. And engagement with a community health worker for community continuity support. Next week, we are going to look at the rest of the 30-day period, and we're going to focus on keeping patients like Mr. Stevenson connected to care. So next week, we're going to talk about that 7-day follow-up, and there may or may not be a missing appointment, and we may need to intervene in some creative ways. Stay tuned. That's what we will be going over next week. In sort of summary, the high yield things here. Make sure you are asking about incarceration early on. Make sure you are focusing on medication and risk stratification, and make sure that well, I think those are the big ones. We'll call it there. Any questions? I'll
Great.
stop now. D-Day, it's yours.
Okay, great. Thank you so much. And if we don't have any questions right now, I'm just going to remind everybody to please complete our post-evaluation survey. Again, please let us know how we can improve in our upcoming sessions. And as a reminder that our next session will be next Monday at 1 p.m. And all the information will be sent out to you, and we will be also sending out a reminder for everybody to join us next week. So I don't see any questions in the chat, but we still have maybe like a few more seconds in case you do.
I have a quick question. I've been thinking a lot about like his blood pressure and making sure that durable medical equipment is offered to him to make sure that he has, because a lot of times they, without having the insurance, maybe the over-the-counter catalog or something like that, that he could purchase. I think I keep going back to the blood pressure too. I mean, I know the overdose is a huge deal, but one of the things I know as a patient care coordinator, I would make sure, besides working alongside with the physician and whoever else needs to be involved, is to make sure that I help get that durable medical for him so that he can have that access to keep track of his blood pressure, medicate, and his stats and stuff like that.
Yeah, I mean, and you fix a lot of problems by doing that. And what I will say is like if this patient were to get like an automatic cuff and to be able to check that and to be able to come in with written or recorded blood pressures, that helps the blood pressure management so much. It tells you a lot more about what that patient is experiencing. Instead of one snapshot in a stressful circumstance, which is a clinical environment, you get what they actually look like at home. So 100%, that is how you manage patients' blood pressure in this circumstance. And as soon as the CHW gets that patient, they would be supporting the team in a very critical way by doing that. 100%. And I will say, in your first visit, a lot of things are going to get crowded out. The OUD was the focus here because of the risk stratification, but come next appointment, we're going to be honing in more on that blood pressure and it's going to be doing some wild things as we untangle the ball of yarn of different chronic diseases here. So very good point. Continue to do that for your patients. That is that helps everyone on the team. That's a team player move, 100%.
Okay, great. Thank you so much, everyone, and we will see you all next week. Have a great day.